Okay, thank you so much. Good afternoon. I'm Kelsey. I'm a Master of Public Policy student at Johns Hopkins University. This summer I've been working at Health and Human Services, helping with the Community Health Needs Assessment being done through the Department of Epidemiology. Okay, so as you have heard, Montgomery County does generally well in health outcomes. We're #1 in health outcomes in the state of Maryland. However, there are still disparities in both access to care and health outcomes across race and income in Montgomery County. The purpose of the Community Health Needs Assessment is to figure out where these disparities in access are and how resources can be best allocated to combat those. For my project specifically, I've been looking at differences in hospital utilization based on race, disease, and proximity to each hospital, and figuring out how resources can be allocated to best combat those issues. I wanted to first show an example of a community benefit service area. There are 6 hospitals in Montgomery County, and every person based on their zip code is assigned to one. And so when I say proximity to hospital as a variable, I'm talking about whether or not they stayed in their community benefit service area to receive care, or whether there was some reason that they decided to go outside of their benefit area to receive their care.
And this is a state designation, that community benefit? Or?
This is in Montgomery County. This is for the 6 Montgomery County hospitals. Okay.
Each hospital has a requirement under the Internal Revenue Service to provide community benefit in its service area.
Okay.
Okay, so on to some results. The first result I wanted to point out was just the disparities in hospitalization, specifically for diabetes. Non-Hispanic Black patients accounted for about 19 to 20% of the total hospital data and 25 to 28% of diabetes-related admissions. This is consistent with the national literature on health disparities. And with diabetes, it's likely that some of these can be prevented with increased access to primary and community care, so I wanted to point this out. The second with proximity is that mental health care utilization was the least predictable in terms of where people decided to go. You can see not only is there a large variation from year to year, but in 2014, we saw the lowest amount of patients staying within their community service provider to go receive their care. This could be for many reasons. One that the national research on this suggests is that mental health care tends to be less integrated into community and primary health care, so people don't have as many referrals as to where they go if they find themselves in crisis. Finally, the people who were most likely to leave their benefit area to receive care were non-Hispanic white patients and Asian patients, while Hispanic patients were the most likely to stay within their catchment area to receive care. The national literature suggests that this could be because of increased flexibility that comes along with an increased likelihood of being insured. So, based on these, I have 3 recommendations. The first is to expand the integration of hospital-specific mental health referrals into community care organizations and information services like Info Montgomery and 311. The second is to increase the monitoring and evaluation of linguistic services being offered at hospitals. Since Hispanic patients are most likely to choose their provider based on location, it's important to make sure that those types of services are implemented equally across every hospital. And finally, to require diabetes management education materials to be required at community health centers and primary care providers, since research suggests that many hospitalizations can be prevented with education on how to manage the disease. Thank you.
Very good.